Morning all, and thanks Simar for the kind introduction. So I would this case this is a case of vascularly active treatment knife stage 4A ROP, and I would like to share what we learned from this. And this was managed almost 10 years ago, so 10 or 8 to 10 years. So this was a 30-weeker baby, 950 gram, was screened late, around 38 week. Had a storming or postnatal course, oxygen for 1 month, had sepsis, anemia, thrombocytopenia, poor weight gain, and all conducive for a severe ROP. So poor mydriasis, vitreous haze, a right eye had a vascularly active stage 4A ROP. In June 1 posterior, we can see that the nasal part, there is a broad ridge and the adjacent detachment, and and with the margin little bit inverted towards the disc. So these are the cases, they quickly close over the disc. This is the left eye. Left eye was a bit better, but the ridge was sitting on a detachment on either side here, circumferential detachment. It was in the zone 1. So laser was planned and laser done, but baby was sick, unstable, with unstable vital. We couldn't complete. So baby has to get admitted in the nearby NICU. So we planned that we probably, and meanwhile the detachment was progressing. So we thought baby would need surgery. So we kept everything ready so that we do injections, laser and surgery together. So this is this is the surgery for both the eyes. A 25 gauge lens sparing vitrectomy was done. The placement of the placement and the configuration of the ports depends on the configuration of the detachment, the extent of dissection that are needed. So these different techniques are available. I do 25 gauge, and this was that valveless cannulas that time. So I tend to put the suture at the end of the surgery to avoid hypotony and bleeding. Now the greatest concern for me are the three. One is bleeding during the surgery. The second is very adequate titrated dissection of the vitreous to relieve the major tractional vectors. As you can see in the right eye, after the injections, 2 days later, 2-3 days later, there is fibrosis and there is contraction over the disc. So if you leave them, then they can lead to crunch effect like the one shown below. So that is why we took the surgery again early, and dissection is being done. The anteroposterior traction is relieved, then the disc to the lateral wall, and very meticulous dissection, just adequate enough to relieve those vectors, because in case a bleeding happens, the blood itself at times can be worse than the membrane, and this can cause failure of your treatment. So laser was most of the laser was done before, and the doing laser has the advantage that, number one, you save time during surgery, especially if both the surgeries are done on the same day. The second, if lens is to be preserved, like here, lens sparing vitrectomy, then you may try to do it pre-op. So this is the last visit 3 months post surgery. We can see that the eyes are doing well with myopic refraction and post surgery. So at 5 years of age, we can see that is doing well. So 3 things I would like to give here: the early screening in these cases, especially the 2, 3, 4 strategy. Day 20 probably would have avoided surgery. And when we have vascularly active progressive stage 4A surgery, my preferred choice is injection, laser, surgery, all as a package, and how early we rush them to the surgery with careful dissection to avoid vitreous hemorrhage decides the surgical outcome. Thank you so much for the kind listening.
Thank you so much, sir, for that very interesting